Then this webinar will be divided in 5 different sections. The first will be a short introduction of the antibody and what kind of mechanism of action could be detected from an antibody therapy, and then 4 different aspects of the preclinical evaluation of this antibody. 2 based on mechanism of action mediated by FAB fragments or FC fragments, and the last 2 sections will be used of humanized mouse models for evaluation of antibody therapy and the use of SPECT imaging. Let's start with the introduction. Then, as everybody knows, antibody is based on 2 different sections. FAB section that mediates the binding to the antigen, and FC fragments that mediate the antibody-mediated effect by the immune function, then immune cells or complement-mediated activity. Then both actions are aimed at either neutralization of soluble antigen that is mediated by FAB fraction of antibody, and all other binding effects than membrane receptor antagonism, like recepting function by binding to R2 targets, or master by binding to CD20. Other function could be mediated by this FAB, and this function could be localization of radioisotope to mediate radioimmunotherapy by targeting antigen and through the antibody the couple of radioimmunoisotopes like yttrium, or the couple of a toxin, highly toxic compound that will be specifically targeted to the antigen and also to the tumor, like a compound like mielotag, which couple kiamycin to CD33 antibody. Other ability of FAB is to design bispecific molecule that will either engage T cells or NK cells to the target tumor cells. Then other functions are mediated by the FC fragments, and this means activation of either the complement-dependent activity, which is the case for 2 known antibodies, CD20 or CD52, and the ADCC activity, then the function mediated by the immune cells that will recognize the FC part of the antibody through the FC receptor, and that will mediate the killing of the target cells. Let's now move to how to evaluate the FAB-dependent efficacy. And first, this antibody is specific of a target and could be used for sure to evaluate the target expression. The best way to do that is that it's mostly designed to bind cell surface antigen than to use FACS analysis. And this is an example of Ramos B-cell lymphoma that express CD19 and CD20. And we use a commercial antibody for detection of CD90, but we use also rituximab, the therapeutic antibody, to evaluate the CD20 expression. Of interest, we can also test more relevant samples than primary leukemia or lymphoma samples to evaluate the population of interest and the B cells. And you have here the result of the quantification of these CLL samples, and most of the cells are of B type with a very high B cell expression. And for subsequent analysis, it could be of interest to purify these cells in order to only have B cells in the assay system. Then the next step is to analyze what is the consequences of antibody binding to the target. The first would be apoptosis induction, and for this we use annexin-5 assay analyzed by FACS analysis. It's an example here for the same Ramos cell lines treated with rituximab and two different concentrations, where we observe that we have a significant increase of this early apoptosis. And we also use secondary cross-linking antibody to stabilize the binding of the therapeutic antibody in order to increase the apoptosis induction. As I said before, a more relevant way to analyze this antibody is to use primary samples. And you have here the results of 5 different primary samples coming from CLL patients, where we compare rituximab, alemtuzumab, and a new antibody, and you clearly observe that depending on the samples, we observe quite no effect of rituximab or alemtuzumab, or a slight increase of rituximab apoptosis induction. And in all these 5 samples, we can compare the effect of these new antibodies that produce very high apoptosis level as compared to both available therapeutics. The next example is based on the binding of circulant targets like VEGF, and for this we have to design another type of assay system, and this assay system will use migration or invasion of cells to analyze the decrease of migration potentials toward VEGF. In this assay system, we've used UVEC cells, which is a cell that migrate toward VEGF, and we have validate an assay system based on a Transwell system. We observe here the increase of migration only due to VEGF, and the decrease of migration in presence of Avastin. In order to increase the sensitivity for this type of assay, we can also use invasion system, which is the same but with a matrigel coated membrane. And again, we observe a very significant increase of migration and then invasion in presence of only VEGF, and a very potent inhibition mediated by Avastin. The next slide is the evaluation of Avastin in vivo, and only FAB-mediated effect, where we used a rhabdomyosarcoma model engrafted subcutaneously, an A673 human rhabdomyosarcoma model, treated by Avastin IP at 5 mg per kilogram. We observed in this model very nice inhibition of tumor growth with a T/C value of 27%, and we've confirmed the effect and the anti-angiogenic effect mediated by Avastin by immunohistochemistry analysis of the mouse vasculature using the CD31 target. In the vehicle treated groups, we observed a very nice vascularization of this tumor model, and in the treated group by Avastin, we are not able to detect any CD31 ladding and any defined blood vessels. Another model to test antibody function and to test Herceptin-mediated effect is BT474, a breast carcinoma model. And I will show you here results that enforce the fact to validate the target expression in vivo. In this BT474 model, we observed a very, very potent effect of trastuzumab given at 10 mg per kilogram, and we observed a decrease of activity, and the dose of 0.1 mg per kilogram is ineffective to our BT474, which is a model that very, very highly express R2 target. Another breast model, which is ADCC 1954, another breast carcinoma model that highly express R2, but are totally unresponsive to the same trastuzumab treatment. And it is very, very important to validate the target in vivo in order to be sure that the lack of response is not mediated by the change of target expression due to in vivo injections of the tumor cells. The last example for FAB-mediated effect is the use of an IV disseminated lymphoma model and the Ramos cell line, and treated by two different compounds. The first is the regular doxorubicin chemotherapy, and also the rituximab, and targeting CD20 at 10 mg per kilogram. You have here the mean body weight follow-up of the animals, and after 20 days we observe a very significant loss of body weight related to Hingle's paralysis of the animals, and few days after the mice are sacrificed for ethical reasons. Only for the group treated by rituximab, we did not observe any body weight loss. The corresponding survival curve highlights a very, very potent effect of CD20 with an increase of the overall survival by at least twofold as compared to the vehicle-treated groups. For this model, an interesting essay is to analyze the charge in tumor cells instead of having only survival endpoints. For this disseminated lymphoma, we have identified various organs that is colonized by tumor cells, and the main location is the bone marrow of the mouse. In healthy mouse, as control for the SPECT analysis, we have no background, and for Ramos-bearing animals treated by the vehicle, we clearly identify the Ramos cells in the bone marrow of these animals. When treated by rituximab, we have a very, very significant decrease of this charge of tumor cells in the bone marrow that is clearly related to the survival increase. Other organs could also be used for such an analysis, like mouse ovary, and which gives the same feature, then significant presence of these Ramos cells in the vehicle-treated group, and very nice decrease of tumor cells in the ovary of the rituximab-treated animals. Another type of model is the use of primary derived models, and in this case is colorectal primary model, where we analyze the cetuximab efficacy in respect to the KRAS mutation. In this panel, I select two examples. This one is wild-type KRAS model, and we observed in this model a very, very nice effect of cetuximab with 100% of total free survival and no reoccurrence of tumor growth. A second model, which is KRAS mutated, highlights effect of cetuximab in the first month after treatment. We also observe 100% of response, but after this first response, we observed 4 to 5 tumors that start to progress again, and only 4 over 10 complete response at the end of the study. And this type of model is very interesting to correlate the genetic profile to an antibody therapy response, regardless the target expression. We will move now to the FC-dependent effects, and the first is complement-dependent activity, and for this, in vitro assays are easily to set up. We've used chromium release assays and RAGI CD20 overexpressing cells to evaluate the CDC function mediated by rituximab. We use human serum to as source of complement. And in the figure here, you have three different types of control: an irrelevant antibody in presence of serum, irrelevant antibody in presence of inactivated serum, and rituximab in the presence of inactive serum. These all three negative controls should be tested in order to be sure of the specific effect evaluated. And we clearly see here that we only observe an increase in lysis in presence of 3 or 30 micrograms per ml of rituximab in presence of human serum. The other way to analyze CDC function is to move forward with in vivo experiments, and for this we need to work in depletion study, then working with the mouse complement and use cobra venom factor to deplete the mouse complement in order to evaluate the complement function in the antibody efficacy. You have here two different types of models. Both are CD20 overexpressing models, and Dowdy or EHRB, and in both cases we observed an increase in presence of the antibody, in increase of survival, and this efficacy of antibody is decreased when the complement cascade is inhibited by the cobra venom factor. And in both cases, a significant decrease is observed in presence of the cobra venom factor, meaning that the CDC efficacy of CD20 is a part of the CD20 rituximab efficacy in vivo. The last function of antibody also mediated by the Fc fragment is antibody-dependent cell cytotoxicity, meaning that immune cells like NK could recognize the Fc fragments of the antibody and then mediate the lysis of the target cells. We also use the same assays, then chromium release assays, again Raji cell lines and overexpressing CD20 and rituximab, and two different experimental conditions. The first is irrelevant antibody in the presence of IL-2 activated and purified human NKs, and rituximab in the same experimental condition. And dose response could be observed when rituximab is added from 0.1 to 3,000 nanograms per ml. This assay is using suspension cells, and other possibility is to also use adherent cells like SCRBR3 cell lines, target and trastuzumab, and as SCRBR3 is overexpressing R2 target, and this experiment was done in presence of PBMCs, also activated by IL-2, but not purified population like AK in the previous experiment. In this assay, we've tested two different effector target ratio, 10/1 and 40/1, and a neurorelevant antibody, and for sure the R13 antibody. And in both cases, relevant antibody only give few percent of unspecific lysis, and we start to observe dose-dependent lysis mediated by R13 as low as 0.02 microgram per ml, and there is an impact of the effector target ratio, meaning that 40/1 give more lysis as compared to 10/1. I said before that it's very interesting to test primary samples in this preclinical evaluation of antibody function. Here is an example of CLL samples tested in the same condition as Raji before. Then rituximab as therapeutic antibody in presence of human IL-2 activated and purified NKs. And in this assay, we observe that in primary samples, no efficacy of rituximab is evident at the dose of 0.3 nanogram per ml, as we observe in the cell lines, and we only observe efficacy at the highest dose tested, and 3,000 nanogram per ml. But this this experiment is very interesting, as we are able to evidence the efficacy of two new antibodies in this system, giving very nice dose response and at dose very low as compared to the rituximab, which is the reference therapy in this pathology. In vivo, we also are able to test the ADCC function in two different ways. The first is using the mouse effectors, then again in depletion study as for CDC mediated function. And this is the result on Raji bearing tumor-bearing animals, testing the depletion of all the mouse effectors. Then first the depletion of NK using two antibodies against the mouse NK, and we clearly observe a decrease of this antibody function. By using liposome encapsulated clodronate, we target the macrophage population, and again we observe a loss of activity of this antibody. And the last effector population, which is the neutrophile, also depleted by an antibody, we clearly show a loss of efficacy. And if all these three depletions are mixed together, the function of antibody and efficacy is totally lost, meaning that in this therapy, only mediated effect is effective towards the tumor, and there is no FAB-mediated effect. I will now move forward with the use of humanized mouse model for the evaluation of antibody therapy. This model is aimed at using human effector and human target cells. This is an example of study meaning at evaluating rituximab efficacy using healthy B cells as target cells and using NKs coming from PBMCs as effector cells. You have here the timelines of the study, starting with preconditioning regimens for mouse effector depletion and whole body radiation, mouse NK depletion through antibody therapy every 4 days. At these 3 IP injections of human PBMCs, at day 14, where we know that the human PBMCs is well disseminated in the mouse system, we have circulating PBMCs, we also have human PBMCs in bone marrow and spleen. We perform an antibody treatment, single dose, and 4 days after, we collect the spleen for evaluation of human B cells in the mouse spleen. You have here the quantification of these human B cells. In the rituximab, in the control group treated with irrelevant therapy, and in that case we use trastuzumab as relevant antibody control, around 7% of human B cells are found in mouse spleen. After a single treatment with rituximab at 2 mg per kilogram, we observed a very, very significant decrease of the B cell content down to 1%, and new antibody was tested in this setup, and dose response of this new antibody was evident. This is FACS analysis that evidence the results described before. Then the control groups treated by trastuzumab with 2 different PBMCs donors. We observed 7 to 9% of B cells in mouse spleen. And after treatment with rituximab at 2 mg per kilogram, single dose, we observed a very nice decrease of these B cells down to less than 1% or 3% for the same donor, then donor 1 and donor 3. Another humanized mouse model could be defined to evaluate the ADCC function of antibody. In this model, the target cells are BT474, then the R2 expressing breast carcinoma cells. A time period is used to let the tumor grow until having a randomization volume of around 200 millimeter cubes. Then human PBMCs is injected, IP, and the antibody therapy starts a few days after until the end of the experiment. This experiment was done in presence of Herceptin alone and Herceptin in the presence of human PBMCs, and for sure without any treatment as control. In this model, a significant effect of Herceptin alone was observed a few days after treatment start. And in the follow-up, we observed a slight decrease of tumor growth as compared to the Herceptin alone group, which is also represented here by the T/C follow-up over the time, and starting at 100% the day of humanization, and decreasing until 60% for the Herceptin alone group. And you clearly see here that the Herceptin in presence of PBMCs is slightly better as compared to the Herceptin alone. The last part is the use of SPECT imaging to perform antibody biodistribution in vivo. You have here the example of trastuzumab radiolabeling, and before moving in vivo for the biodistribution study, it is for sure of interest to qualify the radiolabeled antibody in order to be sure that the immunoreactivity and the dissociation constant of the antibody, of the radiolabeled antibody, is not modified as compared to the unmodified antibody. SPECT imaging was collected after 24, 48, and 72 hours using BT474 subcutaneous breast model, again overexpressing R2, after single injection of indium 111 trastuzumab. You have here the SPECT imaging showing the high specificity of this antibody, and we don't observe significant variation over the time of the tumor signal. The uptake is quite the same over the time, but we observe a slight decrease of the background signal over the time, giving this slight increase in uptake at 72 hours as compared to 24. It is of interest and of importance to validate that the signal obtained through image analysis by SPECT is related to radioactivity present in the organ itself. Then biodistribution through organ collection and gamma counting was also performed in order to compare the image analysis in green and the gamma counting result in blue, expressed through two different analyses, and raw data megabyte cell quantification or % of injected dose. And in both cases, the SPECT imaging quantification is very well correlated to the gamma counting information. The last control to perform is to evaluate the specificity of this radiolabeled agent, modified antibody, by performing co-injection of radiolabeled antibody in the presence of an excess of unlabeled antibody. You have here the quantification of the tumor in the presence of unlabeled antibody, and we clearly observe a decrease of the antibody signal, meaning that the antibody is specifically binding to the tumor target, and there is no change in the blood where no target cells are circulating. This is the last slide of my talk. I hope to give you an overview of all the experiments that is of interest to qualify the mechanism of action of antibody therapy, either in vitro or in vivo, and I'm free now to answer your questions.
All right, thank you very much for this interesting presentation. Yeah, we'll begin the question and answer, and we actually did get a few questions in so far. The first question that came in was, why are you using 51 chromium release assay for in vitro ADCC assay?
In fact, there is many possibility to address the ADCC function in vitro. Either using fluorescent loading level or fax analysis, but in most cases, this procedure is not suitable and not translational between cell lines and primary samples. And the chromium release is the most sensitive assays that are usable and suitable for testing primary hematological related samples, and this is the main reason for keeping the chromium release assays for ADCC evaluation in vitro and ex vivo.
All right. The next question we got mentions on CRIC 013M KRAS with primary samples. How do you explain heterogeneity of responses? Was each tumor coming from a different patient, or were they all coming from the same patient?
All the samples and then all the 10 mice are coming from the same patient, and this is heterogeneity coming from the samples by itself. We don't have performed immunohistochemistry analysis in all these 10 mice in order to try to evidence target expression differences between the 10 mice or various histology of the tumor for the 10 mice that could explain this heterogeneity of response. But the 10 mice in the treated groups come from a single tumor patient.
Okay. Can you discuss the pros and cons of using purified/enriched PBMCs versus NK cell lines?
In both cases, we need to activate the cells, meaning that we incubated PBMCs with IL-2 a few days before using them for in vitro ADCCs. The only main advantages is that using the NKs, the assays is a little bit more sensitive as compared to PBMCs. Then the effector to target ratio is around 5 to 7 using NKs, as it is 10 to 40 when using PBMCs. Then I think that using purified NK gives some additional sensitivity to the assays.
Okay, the next question we got. Is there any difference between mouse strains for humanized mouse models?
Yes, for sure. The mouse strain is, the choice of mouse strain is very important, meaning that there is difference in mouse effector through the strain. And skid mice, not skid, or recently released strain like NOG strain exhibit different effector function of the mouse cells, and there is some need to deplete the mouse effector in regular skid mice, and there is no need to deplete the mouse effector in NSG or NOG mice. Then for sure, the mouse strain is of importance for the humanization process itself.
Okay, and we've got another question here. What is the best model for in vivo ADCC evaluation?
Right now, it's very difficult to answer the question. Literature gave many examples of ADCC evaluation in vivo, either using the mouse depletion system or using humanized mouse model. The best model is probably the humanized mouse model, related to the fact that the recent version of antibody is fully human and need humanized effector to mediate their function. However, using PBMCs for humanization give a short window of analysis due to the fact that using mature PBMCs led to graft-versus disease within 3 to 4 weeks, depending on the experimental settings. But you have mature cells and functional cells. In the opposite, you can also use stem cell-based humanized mouse model. And right now, it's clearly demonstrated that the human NKs that differentiate from the stem cells is not fully functional and need external supplementation by either IL-2 or IL-15. That for sure the humanized mouse model is the best way to evaluate human therapeutic antibody, but right now the experimental setting is close to the goal, but the goal is not reached.
Okay, we've got one more question here. For in vivo, what's the ratio of effector to target you would recommend for ADCC?
In the experimental setting we've performed, we used the regular model we have in both sides. There's a 10 million as inoculum for tumor target cells, and we use 30 million PBMCs IP for the humanization process. In most of models performed, we observed a trend in increase of efficacy of antibody in the presence of PBMCs, but this is only a trend and not statistical results. I think that 30 million PBMCs toward 10 million tumor target cells is far as compared to what we need to test in vivo, a ratio of 10 to 1 or 40 to 1, and we have to decrease the inoculum of tumor cells in order to be sure that we have enough effector cells to control and mediate the antibody function toward the tumor target cells. And probably we need to increase the effector to target ratio in vivo. And right now the 3 to 1 ratio we have is not enough to produce statistical significant results. Then I don't know the target that should be achieved, but 3 to 1 is not enough, and probably we have to test 10 or more in the next experiment.
Okay, I think that's all the questions we have for today. So I'd like to thank you again for a great presentation, and I invite everyone to visit Taconic.com for more upcoming webinars. All right, thank you everyone, and have a good day. Bye-bye.
Thank you.